The next few lectures are all going to be about the heart. So it's kind of in the series going from just your vasculature, diseases of the vasculature or peripheral vascular disorder, and then going just straight to the pump of the whole thing, the heart, where we're going to be talking today about just general disorders of cardiovascular function, and then we'll get into ECGs or EKGs, where we'll talk about all those little lines on a sheet of paper. Let's see, this is not working. There we go. So cardiovascular disease, obviously, like we said last time, is an important thing in the U.S. It's 1 of every 5 deaths. So obviously, y'all being nurses, y'all are going to interact with this probably on some level, depending on if you enter any specialty. But generally speaking, a ton of people have cardiovascular problems. It's just a lot of people, hundreds of thousands of people every year die of this. And what's a fact about this is that it doesn't really discriminate insofar as it affects both males, females, young and old, of all races. And so it's just a very important thing to know about. Now, with regard to the types of diseases that occur with heart dysfunction, we've talked about aneurysms briefly, but there's also valve diseases where you have problems with the valves opening and closing, we'll talk about today. Also coronary artery disease, where you have blockage of the blood supply to the heart, which we all know is heart attacks. We mentioned that briefly, but we are going to talk about that extensively in the next lecture, where we have the entire lecture just talking about that. There's also cardiac arrhythmias, which we're going to talk about in the 3rd lecture today, where you just have a misbeating of the heart, and we'll look at the ECGs of what that looks like. There's also just generalized heart failure, cardiomyopathy, where you have problems with the actual physical nature of the pumping, right? Myo is referring to the heart muscle, right? So cardiomyopathy is diseases with the actual heart muscle, and then there's also just pericarditis. We're also briefly going to talk about congenital heart disease of just young children. So that's what we're going to talk about largely today. Now, we're going to talk about all these. We're not really going to go over aneurysms today. So the rest of them are in this lecture, except for coronary artery disease. So we'll be talking about these in particular today. Now, risk factors. There are certain risk factors that are associated with these things. There's non-modifiable and modifiable. You can think of non-modifiable as just things that you cannot change, right? We're all going to get older. There are things about our genetics that we can't modify to any really significant degree. But there are certain things that you can change, right? Your ability to stop smoking, move around, get exercise, eat right, go on diets, meditate some more, and then prevent infections, where these things that absolutely are associated with bad blood flow through the artery are absolutely also connected to heart function, insofar as that these things absolutely cause problems with the heart just as much as they do the vasculature, like we talked about last lecture. As far as diagnostic tests for cardiovascular function, there's a lot that can occur. There's ECGs is probably the most common one, where you're looking at the electrical signaling throughout the blood, but there's also just looking at the heartbeat. Exercise stress tests, where you stress to see how well it responds to you test to see how well the heart responds to going through exercise. There's also chest x-rays, where you can look at the heart, and catheterization. There's also this thing called angiography, where you can actually look at the blood vessels and blood flow to the heart. In particular, you're looking at the coronary artery and feeding it. So you can see here in this vein right here, you can see that it kind of stops right here, right? But after you reopened it, you can see that there's more blood flow. So the darker regions are where you get blood flow, right? There's also echocardiograms, ECGs, that we're going to be talking about extensively. and also blood tests to look at certain markers, looking at cholesterol levels, which we all know is associated now with just blood flow in general. And then you can also look at blood oxygen levels to see how healthily blood is moving throughout the body. There are treatments for this, right, where you're looking at, largely it's going to be tackling the things that you can control, those modifiable things that we mentioned, things like starting to eat right, regularly exercising, stopping smoking. All these things are absolutely things that we can control. But for the things you can't control, you can also go in and have surgical modification of these things, where you can do things like all the famous surgeries we know about heart disease with regard to doing bypass surgeries or putting in shunts. We're going to talk about replacing valves in the heart as well. It's things that you can modify for if there are problems that you can't control. But largely speaking, I think most of the problems are modifiable things. Just we as a country and generally as the world just don't really take care of ourselves at a mass population level, and so it's really targeting those things to nip this thing in the bud insofar as don't have these problems that cause these cardiovascular issues, and then telling patients to take care of themselves, some things you just can't control as a healthcare provider, obviously, but that's how you kind of want to guide people through preventing and fixing their cardiac problems. So what we're going to do is we're going to kind of go inside out when we talk about the problems, and so we're going to start within like the actual chambers of the heart and actually the cell lining of the heart. And so the thing that makes up those cell lining are endocardial cells. So endo meaning they're part of the vasculature, right? And then cardio is they're part of the heart. So these are technically different than the endothelium that line the vesicles, but they're very similar in a lot of aspects, and that they guide movement of the heart. Now, what's very true about these though is that they form. Well, okay, that's the next slide, I guess. These are what we're going to be talking about. So we're going to talk about the inside, that lining of the heart, and then we're going to move just progressively out. Admittedly, we're going to talk about the very outer lining of the heart, the pericardium. But then we're going to just go from the lining to the muscles, and then we're going to talk about infants at the very end there. And then the next lecture we're going to really go into feeding of the heart muscle. But yeah, like I was saying, that there's the endocardium that lines inside of the heart, and importantly, it covers the valves. So these are the cells that make up I think, did y'all look at the handout that kind of goes through blood flow? I know it was super basic, but I'm just trying to review kind of what y'all learned in physiology. I know y'all got a test today, so it's cool if you didn't look at it. Hopefully, though, you will just remember blood flows right atrium, then it goes through this tricuspid valve, and then moving to the right ventricle. Right, vent means to send, so all your ventricles send blood out. The right ventricle sends blood out to the pulmonary artery, which then you have a gas exchange in the lungs, and then it comes back in through the left atrium. Then you have more valves, left ventricle, atrium, right? Atrium, just like an atrium of a house. It's like a Latin word meaning a place where you accept things. So if you're accepting people in your house, that's your atrium, right? But if you're a heart, you're accepting blood, you're sending it through a valve to left ventricle through another valve, and then to the body and the rest of the tissues. Just briefly now, so you are kind of expected to have that reviewed. So if you don't remember it, whenever you go to study, just take a look at that handout, and it should go over all the things you need to know for that. Regardless, though, all this blood flows through the heart. It's all covered in endocardium, right? And the valves are made of this same tissue. So there can absolutely be problems with these, right? Just like pretty much everything in the body. Insofar as when you don't have proper valve function, obviously, do y'all know what valves do, generally speaking?
Control blood flow.
Yeah, importantly, yeah, they absolutely control blood flow, but it's more that thing where they open up, allow blood flow, and then close up to prevent backflow, and it keeps things all moving in the same direction. So obviously, if you have problems with that and you do have backflow or you don't have proper opening, then you're going to have disease states. So these problems, though, with the valves, they can be from a number of things: being hit pretty hard, congenital issues, ischemia, deuterium changes, or inflammation. So you can imagine that, like, for example, inflammation. If you have a valve that's inflamed, well, one of the cardinal signs of inflammation is to get bigger. Well, if you have a big valve, you can imagine it may not open as much, and so you don't allow blood flow, right? So it's all about just the physical nature of opening and closing that all these problems arise. So there are mitral and aortic valves are the most commonly targeted, and the valves just won't. You can either have regurgitation or stenosis. So regurgitation is where it won't close all the way, and you do get backflow, right? And stenosis is just it's not opening properly or fully, and so you don't have blood flow insofar as blood's not going through that opening as efficiently, and so you're not getting enough blood out to either the lungs or the tissues, whichever valve it might be, right? If it's on the left or the right side. So a way to remember this is, so stenosis is kind of like you're stuck shut, so you're not opening. So everything starts with an S, right? Now, we're going to be talking about coronary artery stenosis later on, and that's not like a valve, right? So it's not always you're stuck shut. What really stenosis is that it's just you don't open fully, and so you have a more narrow opening, right? So don't get married to that, but it's just a way to remember the difference between stenosis and regurgitation. Regurgitation is kind of easier for me, I guess, because it's like, I don't know, it's like kind of a normal person word. Yeah, right. So, or like, yeah, y'all got it. So, yeah, just make sure you're familiar with those terms for the test. Now, as far as what you can have all kinds of problems with this, right? So the first one we're going to talk about is infective endocarditis. So you know that endocarditis, what do we think that is just from the name alone? Yes, the endocardio, and then the itis is inflammation of, right? So it's inflammation of the lining of the heart. So obviously that's what that is, where you have just things, you have an inflammatory response, usually in response to the presence of bacteria, but it could be other things as well. And obviously, if you have a bacterial infection, we're going to treat it with antibiotics. We're just trying to target the bacteria to get rid of them, and if you get rid of that, the inflammation will go down. And then the way that you diagnose that is with culturing whatever that bacteria is that's causing that, and you can confirm or get rid of that diagnosis. There's also rheumatic heart disease, and this is due to a rheumatic fever. So again, it's immune mediated, just like we learned that fevers are. And it's typically caused by group A streptococcal bacteria. Do y'all know what the main thing that these bacteria cause? Yeah, strep throat, you got it. So, so what usually happens is that if you have strep throat that's not dealt with, it can make its way to the heart and cause secondary problems. So you want to make sure to nip that in the bud as soon as you can, but this doesn't happen. And the way that so the symptoms are that you have rheumatic fever, and the way that you diagnose this is with a throat culture, right? Because usually that strep is still there in the throat, and so you can still diagnose it that way, but then also just seeing it on an echocardiogram. And again, because it's bacteria, we treat it with antibiotics as well. And you can also just turn the inflammation down, turn that fever off by taking, anti-fever drugs. And so you're going to take anti-inflammatories to deal with it.
So hypothetically, caused by strep or streptococcal, if you get strep throat and you don't treat it, could it eventually cause problems to your heart in advance to this?
Yeah, that's exactly what's happening here. Now, it's not always going to happen. It's not like a guarantee, but
it's like an advanced stage of
yeah, because sometimes your immune system can just deal with strep infections for sure, but a lot of times it doesn't, and that's when you get sick. And yeah, so that's usually when you go to the doctor and then you deal with it before it really gets bad. But this is like if you just ignore it and you just let it fester, yeah, you can have heart problems, absolutely. So we also have, so when we look at these things, we're diagnosing valve defects. Blood going through the valves make noise, right? And so these, when there's a backflow, right? When you have valve problems, you have this thing called a murmur. And so if you check Moodle, I put some videos on there kind of that go over the different types of murmurs that you might hear. It's like a Khan Academy video, but it gives you all the kind of the experience of what you would hear if you were to listen to murmurs, and they go over kind of different types of murmurs. Now, you're not going to be expected to know that, so do this on your own free time. But it is interesting to just kind of listen to it one time. There's 2 videos, and so you can kind of just do that. They're not super long. Do it once and then just say you had the experience. But you won't be expected, like you're not going to get some audio bite on the test and then expect you to know which one. So don't freak out about it. But if you're interested in that, you can go look at those videos. They are on Moodle. So it tells you kind of what a murmur is. But they are classified kind of how they sound in and of themselves. So they can be high pitched, low pitched. They could have how long they last, or all kinds of characteristics auditorily. But what's important is that you can also see them with an echocardiogram. I'm going to call echocardiograms either ECGs or EKGs because they kind of exist both in my head. Y'all know the difference between the two? They're the same thing, but like why one uses a K and one uses a C? You never heard this? So the way they spell cardio in German is with a K. So the German way of doing it is EKG. And that kind of got hooked on, I think, from doctors that came from Germany. But in America, they're trying to make a transition over the past, I don't know, 100 years or whatever. I don't know how long. I don't know the full history of it. But they're trying to spell it the American English way with a C, right? So that's the only differences between the two. So I'm going to ping pong back and forth between the two, but know that they are the same thing, right? So what's really cool here is you can see murmurs with just visually. You can see, like, looking at turbulent flow, you can see that there are problems with this that light up. This is like an ultrasound of the heart. So you can look at turbulent blood flow and you can identify where in the heart it is. This one, I think, is right by the aortic valve, right? So you can know where these problems occur with those ultrasounds. And interestingly, I didn't even know this until I read it. You can replace valves. So if you do have these valve problems, you can go and have surgery and get these mechanical valves inserted, and they just act like how valves are supposed to. What's great about valves is there's no like electrical control like there is with the heart, and so it's just a flap of skin, an endocardium that just opens and closes, and so you can put, I'm guessing it's like probably like a plastic or something, I don't know, but you can just put that mechanical thing in there, and then it acts the same exact way. So it's a nice little way of repairing that thing.
So do they attach them to the muscles in the heart to control the natural valves?
So do they attach them to the muscles that control the valves?
Like the papillary.
Oh, I know what you're talking about. So I don't know all the ins and outs of it. It's a good question. But it doesn't look like it, in so far as it looks like it's a lot of mechanical stuff. But that's a good question though. Okay, so yeah, that's a lot of the valvular disorders. We're also going to talk about disorders of the pericardium and the outer sac. This is disgusting to me. It's very disheartening. It looks like all white and stuff. Looks weird to me, but you can see it's a great picture of the pericardium. It's just this little sac that surrounds the heart, right? And what it does is it's like this fibrous sac that encircles the heart. It isolates the heart from other structures, and there's like a little bit of liquid inside of it to where it prevents friction from occurring. Where you talk about when that liquid isn't working well, or the sac is inflamed, you have like rubbing of the heart against the pericardium, and that's not good. Apparently it's really painful. But It also maintains its position in the thorax, right? So it makes sure the heart stays where the heart's supposed to be. It prevents it from overfilling by providing that physical barrier, and it's a barrier to infection as well. But there can be all kinds of disorders with it. So what I want y'all to focus on with this picture is that it's not just a single cell. It actually has pretty organized layers here, and that you have this fibrous pericardium, and then you have the peritoneal pericardium. So there's 2 layers here, and then you have this cavity, which usually has liquid in it to make it frictionless. So you have like this organized layer here that make up the pericardium. So pericardial disease are frequently associated with other diseases in the heart surrounding the structure. There's acute pericarditis, there's constructive pericarditis, and there's pericardial effusion. And one of the dangers with that is this concept called cardiac tamponade, which we're going to talk about. So with acute pericarditis, it's kind of what you'd expect, where you have acute inflammation of the pericardial tissue, right? You can just break down that word. And it can be caused by a number of things, being bacterial or viral, with connective tissue disorders, with chest trauma, drug toxicity. But what happens is when you have inflammation is that it's just you have increased capillary permeability, right? So just like you have with all inflammation, that you have increased vascular permeability, you're getting immune mediators out, these immune cells out of the bloodstream, and you're causing inflammation at that site. And so when it is the pericardial tissue, it causes all kinds of problems with that inflammation. Associated with exudate containing proteins, right? So all the inflammatory fluid as well, with all those cytokines and antimicrobial peptides that might be in there, all that's going to go in, and so you're going to increase the fluid in there as well. And what can happen is that these chemicals in the inflammatory response can cause scar tissue to form, and it can cause some serious problems there. So about 30% of those acute cases result in chronic recurring cases, where it's just occurring a lot of the times instead of just a single time. So it can be a pain. When we talk about acute pericarditis with the symptoms, it's going to be very painful because of just everything's not fitting right. You have inflammation, and so you have mechanical pressure that builds up, and then that pressure is detected by pain. And then, so you have this like sharp stabbing sensation. And what's interesting about acute pericarditis is that when you lean forward, the pain goes away, probably because you're shifting all the weight and pressure to a different area. And so that's one of the important things that can distinguish acute pericarditis from other things. So it's really important that you know that symptom, because that's going to be like what's on the test, insofar as it's going to be like, this random person, blah, 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 a whole bunch of dumb information. Then it'll say pain is relieved by moving forward. And then that's what's going to be identified as acute pericarditis, right? So just make sure to focus on these things. And that's kind of what you want to do throughout this class, is you want to focus on the things that can distinguish, that are almost unique to these conditions, right? When you have these like unique things, that's how you really, really identify them. And it's these cardinal signals that can distinguish. But you're also going to see EKG changes, and you might have fever, right? And so when you diagnose these things, you can do this a number of ways, but it's with that chest pain or with the EKG. But you can also look at it with, that's kind of funny. I put EKG and electrocardiogram, which are the same thing, right? So, but what you can do is you can take NSAIDs, these non-steroidal anti-inflammatory drugs, and you can reduce the inflammation that can cause a reduction of the pain and some of the inflammation. When we talk about constructive pericarditis, what we have is a chronic inflammation, right? So that was acute before, and now we have chronic now. And you have scar formation starting to form between the visceral and the peritoneal layer of the pericardium, and you get these friction rubs. This is what I'm talking about, that when you have this inflammation, you have disruption of the cavity in between it, and so you get rubbing of the pericardium with the heart, and so that's apparently very kind of hard to. Apparently it's painful. Where you have increased, but this is also so you have these scars form, and then it's going to restrict the diastolic filling because the heart can't expand because you have a scar tissue that sac isn't being liable like it's supposed to, and so what it's going to have is you're going to have increased venous pressure, decrease in cardiac output because you're not right. The contraction is part of the contraction of the ventricles, the expansion of the ventricle, and there's going to be pulse pressure and then fluid retention as well.
Did you say the cardinal sign?
So it's really just looking at the friction rub and the scarring of the pericardium. So treatment is just removal of that is the restrictions caused on the pericardium. Symptoms are going to be dyspnea, fatigue, edema of the extremities, right? Because you're not getting that proper blood flow with the proper contractions. A swollen abdomen, weakness, muscle wasting. You're just not getting proper blood flow and oxygen and nutrients to the muscles, so you're going to be tired and weak and stuff like that. Okay, so there's also pericardial effusion. So that's the accumulation of fluid in the pericardial cavity. It's where you have too much fluid in that cavity. You can kind of look at the picture there. And what that does is that it causes similar pressures on the heart, right? To where the fluid is kind of pushing back on what the heart's trying to do of expand and contract. And so there's three factors that determine this: is the amount of fluid in that. There's a normal amount in there, but when it gets to be a lot, so there's usually 15 to 50 milliliters of fluid. That's normal. It's when it gets to like 200 milliliters, and that's when it starts to become problematic. But there's also the length of time the fluid has to accumulate. So if these are chronic or if it builds up quickly, and then it's the elasticity of the pericardial sac. If you have a more elastic pericardial sac, the fluid's just going to push the sac outward, and it doesn't push on the heart as much. But if you have more rigid sac, it's going to push more on the heart and cause more problems. Makes sense, right? So when you talk about types of pericardial effusion, there's very small. It has different levels, right? So there's very little amount of fluid in where you're not really going to have anything. You're probably not even going to notice it. There's where you have, and then this thing there could just be more fluid up to 200 mils, and that's developed slowly. Again, there might not even be symptoms. You might feel a little weird, but nothing that like alarms you. The problem is when you have these sudden pericardial effusions that raise the intracardiac pressure, and that really causes the problems and where you're reducing the venous return from the tissues, and then you're not allowing the blood to expand, right? Sorry, the heart to expand for the blood. So symptoms of that, again, a lot of the similar stuff: discomfort when breathing, lying down, chest pain, and chest fullness. So what I want to mention here is that that's what distinguishes from acute pericarditis, is that the pain is relieved with acute pericarditis, but with but with this pericardial effusion, it's when even though you're lying down or you're trying to relieve that pressure, you still have pain. So that's a big distinguishing factor, is this pain about different positions in the body. Again, it's going to be diagnosed with the EKG, X-ray. A lot of these heart conditions are going to be diagnosed very similarly with X-rays, CT scans, MRIs, EKGs, all of that kind of stuff, right? And the way that you treat it, again, you're just trying to reduce that inflammation that's causing the fluid buildup. So you can take things like NSAIDs, and you can go in and actually like get a needle and stick it into that cavity and then withdraw a lot of the fluid, just physically relieving the pressure buildup. Apparently that happens a lot on these like drama doctor shows where they like Grey's Anatomy, ER, Scrubs, all these things. They're super dramatic. They can just like stab with a needle and relieve this pressure. But regardless, that is a way to do it, to where you're just taking that fluid out. Now, with regard to consequences of this pericardial effusion, there's this concept called cardiac tamponade, where you have timpanade. Yeah, I guess there's all kinds of pronunciations. Where you have rapid accumulation of the fluid, you have compressing of the heart. So this is when it happens really, really fast. You have restriction of the ventricle filling. Again, all that stuff that's associated with pericardial effusions that we mentioned is very much applicable here. You have increased contractility. You have tachycardia, where you have increased heart rate. Right? We'll talk about that in 2 lectures, where you have an increased heart rate, and that makes sense because you're not doing the maximal ventricle filling, and so your heart is trying to compensate by pumping faster, still getting the same amount of blood out to the tissues, but it just can't expand and pump properly. So it's going to increase the heart rate to do that. So something that causes the causes are anything that causes the sac to fill with fluid, where you have blunt trauma, you have rupture of the heart following myocardial infarction, MI, complications during percutaneous cardiac procedures or device implantations, retrograde bleeding during aortic dissection, and it's a very, very important thing to get treated. Because it is a life-threatening condition. So the big thing here is you have, I think is it the next slide? No, I guess I don't have that on here. But what you want to be looking at is, I have it? Yeah, okay. You want to be looking at where you have a 10 millimeter fall in systolic blood pressure with inspiration. I think one of my questions later on, it's like a picture on the practice test. It's like a picture of that, and you'll see like this region of inspiration, and you can see the pressure just gradually falling. So be on the lookout for that whenever we're taking these tests, right? But that's a big thing with this condition. All right, so we're now next going to look at the cardiomyopathies, right, where you're looking at that region with regard to the actual muscle that is the heart. So with cardiomyopathies, these are disorders of the heart muscle itself, usually associated with disorders of myocardial performance, which may be mechanical or electrical. And we'll talk about arrhythmias, thank you. That sounded weird. We'll look at arrhythmias in the 3rd lecture today. That's like what that one focuses on. But there are primary cardiomyopathies where you have it's not due to another condition that weakens the heart, but rather it's the problem itself, and typically caused by genetic or inherited factors. But then there's also secondary cardiomyopathies where it's other conditions that cause it, things like hypertension, chronic alcohol use, diabetes, and obesity, right? So with these cardiomyopathies, you have cardiac hypertrophy, right? What's that? Do you all remember? Hypertrophy? Yes, when the cells get bigger, right? So this is just when the heart muscle cells get bigger. So you can expect that if this is a normal heart right here, you can expect a thickening of those ventricles, right? A lot of times it happens with the ventricles. And then the opposite of that is dilated cardiomyopathy, where you have a thinning of those. Both are problematic. This one is problematic. The hypertrophy is problematic because the thickening of the wall itself, it can cause the ventricle to get smaller, and so you can't allow as much blood through. That kind of makes sense. So it doesn't allow as much blood through, so you don't get as much cardiac output. This one's obvious. When it gets thinner, that's also problematic in that this muscle is not strong enough to pump the blood, right? So it's this Goldilocks region that's really a healthy person. So you want patients to not have either one of these problems.
So what's the difference between cardiac hypertrophy and a highly trained athlete?
Yeah, so I think we actually have more hypertrophic cardiomyopathy. Yeah, so that is one of the things that happens, and that is something that you can actually see on the electrocardiogram, where you have a cardiomyopathy with just people who are athletes. So it's not necessarily always problematic if you have a thickening of that heart, because sometimes just normal physiological adaptation to a different environment. It's when it becomes so thick is that it really impedes blood flow into the ventricles that it becomes actually problematic. It's a good question. So even within the problems themselves, it's this Goldilocks region where you want to be paying attention to things. So causes of this, so just like you were saying, athletic training is a cause of cardiomyopathy. Not always problematic right? It's not a bad thing to work out, if that's what you're asking. But it can, so just an enlarging of the heart isn't necessarily bad in and of itself. It's when it's the secondary conditions of not having enough blood flows when it comes to problem. But there's also aortic valve stenosis. Do y'all remember what stenosis is? Yeah, it's a narrowing of that valve. So that's a problem because you have a narrow valve, your heart's compensating and pumping and growing to pump harder because it's trying to make up for the blood flow that's not coming in, right? And so we'll talk about this in a little bit, but it's your heart adapting to these stressors and trying to make up for another problem that's upstream. Hypertension, obviously similar stuff, right? You're narrowing of when you have an increase in blood pressure, your heart pumps faster, right, or harder. There's also genetic disorders as well, autosomal dominant disorders in genes encoding contract proteins. So the consequences are what you'd expect, right? A thickening of the ventricle septum, abnormal diastolic filling, decreased ventricular filling, left ventricular outflow obstruction, cardiac arrhythmia, and cardiac fibrosis. As far as symptoms, you can have chest pain, coronary artery disease, fainting, and then a risk of sudden death. So it's not something to take lightly. But you can diagnose these things with EKGs, like we'll talk about in the EKG lecture. And the treatments are just symptom management, medication, and possibly even surgery, depending on how bad it is. And surgery, yes. So there's also the opposite of this, dilated cardiomyopathy, common cause of heart failure leading to indications of heart transplant. Around 35% are familial cases, so there are genetic components. Causes an increase in infections, toxins, alcoholism, chemotherapeutic agents, and there's the DCM is the dilated cardiomyopathy. So there's idiopathic, so there's no cause necessarily for this thing. Progressive cardiac dilation and systolic contraction dysfunction. And the heart is enlarged, so the heart's typically enlarged 2 to 3 times normal weight dilation for all 4 chambers. So everything's going to be getting bigger, especially the left ventricle, because there's no muscle there. So it's kind of making up for, it's kind of doing the opposite in that it's allowing so much blood in and blood out to make up for the lack of contraction, but it's very much problematic. So the symptoms here are reduced exercise capacity, you can't work out as well. So when you do things like stress tests, they're not going to perform as well as you expect. End-stage ejection fraction, thrombus formation, right? We talked about this in the thrombus lecture where the blood's not flowing well, and so it's almost like pooling, and so it's becoming sticky, and then you get blood clotting in the veins. Mitral valve regurgitation, because you're not getting the blood out, right? And abnormal cardiac rhythms. Again, I think we'll see this I think we go over this in the ECG lecture as well, so more on that. Now, obviously there's death due to heart failure, can occur suddenly. Again, very dangerous. Treatments, as far as treatment goes, there's symptom management, medication, this is a thing that you might a pacemaker put in, and then lifestyle management, trying to build up that muscle, right? Again, ECGs, I did it again, ECG and EKG, ambulatory monitoring and MRI. So that's cardiomyopathies. Next, we're going to talk about heart disease in infants. And then the next lecture, we're going to tackle coronary artery disease, right? So as far as with infants, there's disorder of blood rates in the heart. Approximately 1 in 125 infants are born with a congenital heart defect, make it the most common form of structural birth defect. I think second's like hearing loss, if I remember correctly, but that might be wrong. Ignore that. But there can be long-term survival, and positive outcomes have increased with better medical practices. With these congenital heart defects, there are major developments occur between the 4th and 7th week of gestation, and most congenital defects occur during this time. There's a number of issues that can cause these things, ranging everything from genetic disorders to environmental things. Interestingly, there's also infections that can occur that can infect your heart. The most common infectious cause of congenital defects across the board, but particularly with heart defects, is this virus called human cytomegalovirus. We mentioned it actually briefly. Do y'all remember what we mentioned it in? Yeah, it was the first test we had. So it had to do with mononucleosis. So this caused. Wait, what? Yeah, exactly, which is mononucleosis. So with mono, the most common cause is EBV, which is a herpes virus, but the second most common cause, about 7%, is the same thing. So, and that has to do with the viral. I know more than I should about this virus because this is what I personally study. But what happens is that you infect your throat, causes mono. But what can happen is that it turns off the immune system, can go into it's a concept called latency, and then what'll happen is that it'll eventually infect the fetus, and it'll infect these heart cells, and then it'll cause problems with the heart development. So but that's neither here nor there. We might go more into this virus whenever we talk about viral infections. I think it's like the very last lecture. It's either the second to last or the last lecture. But yeah, but all you need to know though, and honestly you don't need to know it for the test, is that there are infectious, which is just an example of an environmental condition that causes congenital heart defects. So these are classified in different ways. Where the heart defect is, if it's in the atrial septa, ventral septa, it can be anywhere. But there are hemodynamic alterations. Hemodynamic is what I mean by that is the flow of blood through the heart, right? So there are just alterations with that caused by these anatomical defects, as you'd expect. There's effect on pulmonary blood flow and tissue oxygenation. Again, makes complete sense that when you have defects in the heart and you're not getting blood, you're obviously going to have problems with getting oxygen to the tissues, because that is the main thing that red blood cells do. So treating infants is a lot harder than treating adults, but there are ways that you can diagnose this with, again, things like ultrasounds, chest x-rays, all kinds of stuff. And what you really want to do is just have supportive therapy to correct these things. Yeah, we'll just leave that there. Okay, so with regard to, there's all kinds of hemodynamic alterations, meaning blood flow problems. So there's left to right shunt and right to left shunt. So with regard to this, this is right on if you were that person, right? So I flipped it because that's the patient's right and the patient's left. Does that make sense? It's like you're looking at the person. So this is when blood moves from the left to the right in the patient, looking at them. Does that make sense? I got that. Okay. So obviously, if you're moving to the right part of the heart, the right part of the heart does what? It sends blood to the lungs, right? And so more blood. This is when more blood goes to the lungs, right? Yeah, exactly. And then the opposite is just that flipped, right? To where more blood is going to the tissues and less is going to the lungs. So you can imagine that if you have this one, you have deoxygenated blood goes out to the body, which is bad, and that concept is called cyanosis. But that's just where you're not having oxygen delivered to the tissues, just like you said. Make sense? So there's other problems. So there is patent ductus arteriosus, where you have high blood pressure in the aorta. So I took this picture from the textbook, and it's where it's shunted back to the pulmonary artery. You have atrial septa defecta. I think that's down here. Yeah, right here, where the blood is shunted from, it's that left to right shunt that we just saw, and then the ventricular septal defects is where it's shunted from the left to the right. And you can look at, so you can kind of use these slides. I guess I should add this slide before the last two, but whatever, it's fine. There's also endocardial cushion defects where you have blood flows between the chambers of the heart. Very problematic, right? I say that there are animals, not humans, obviously, but there are animals that like only have one ventricle. There we go. I'm having problems with words today. There are animals that just have one ventricle. I forget how their anatomy really works, but they make up with other very different anatomy with regard to the blood flow. If you take like a animal physiology class, you'll learn more about that. That's how I took physiology. I took vertebrate physiology, and I think maybe it's like frogs if I remember correctly. I don't know. I'm just talking right now. But this is problematic for humans for sure. There's also pulmonary stenosis, right, where you have a stuck shunt where everything starts with S. You have decreased pulmonary blood flow and right ventricular hypertrophy, right? Your heart is compensating for these problems. There's also tetralogy of Fallot, where you have Fallot. There you go. Where you have ventricular septal defects, dextroposition of the aorta, the RV outflow obstruction, and hypertrophy. And you're going to be cyanotic there, right? So to where you don't have proper blood flow to the proper oxygenation. There's also transposition of the great vesicles, where you have pulmonary artery is attached to the left side of the heart and the aorta the right side of the heart. It's just not how it's supposed to be. And the postductal coarction of the aorta, where you have aortic narrowing. So that's all you need to know for this stuff. So what we'll do is we'll take like a 10-minute break, and then we will come back and we'll talk about the coronary artery disease next. But y'all can take a little break and we'll come back.